call the meeting to order of the North Broward Hospital District Special Board Meeting, July 26, 2018. Roll call, please.
Commissioner Klein?
Here.
Commissioner Uri?
Here.
Commissioner Wellens?
Temporarily absent.
He's here.
Commissioner Dirk Watt? Here. Commissioner Barry?
Here. Okay, we did the Pledge of Allegiance earlier.
Okay.
That covers us for today. Public comments. Are there any public comments?
There are none.
Okay, let's proceed to the topic of discussion, which is potential metrics to be used in a balanced scorecard for management incentive compensation plan. Gino Santoria.
Thank you, Mr. Chairman. I'll try to be very brief. If we go to the fuchsia book here and open up behind tab 1 on the third page, I'll try to give an overview. On this third page, what we have is our balanced scorecard, which should look like this with the dials. This is the conglomeration of all of our KPIs that we feel to be an important report card of where the health of the system is. How we got these, let me speak briefly to that. How we came up with these measures is, some of these measures have been in place for a long time, just in different areas. So HCAPS, for example, and some of our quality measures, our core measures, they've been used within the system for greater than 10 years.
Gino, can I interrupt for a minute?
Sure.
Is this identical to this?
It is.
Because this is a lot easier to read.
Absolutely,
Okay.
it is identical. So we've added a few new ones as well, and how we came up with the pillars is we took a look at a lot of public information out there from a lot of different benefits groups who have helped to construct scorecards for health systems. And what you'll see is, and it was a presentation I gave a few board meetings back, but out of all the different indicators, there are 5 that are really key that you see across the system, and that's, we've included all of these. So we have operational efficiency, which is net gain loss from operation, that's on top. We have quality and patient safety, which again has been utilized for a long period of time here, and those include hospital-acquired conditions, value-based purchasing, and HCAPS. Then we have people, so we chose productivity and then voluntary turnover, which are 2 of the most important ones from a KPI perspective. And then we have, for compliance, this one is a little unique. So, and I mentioned this before, compliance is generally not on a balanced scorecard. It's necessary and part and parcel to an effective organization. But the board has expressed their desire in the past to put an extreme focus on compliance. And so we, with that foresight in mind, we've added compliance, and it's really just the monthly compliance and ethics reports and then the annual management certification. We've added those, but those are certainly open for change. And then the last part is patient flow. The thing to remember about patient flow is this metric this year is going to be the percentage completion of our planned teletracking implementation. After it's implemented, that metric will change, and we'll start to have some of the other patient flow indicators in there, such as EDS bed turnover time, decision to admit, things like that. So the first year, we're focused on getting it implemented. The second year and beyond, it will be on the metrics that are industry standard. So that's what this scorecard is. We're using this internally to measure the success of our health system. We felt that this would be a great base for the board to look at and discuss in terms of utilizing a balanced scorecard that may be synonymous with a management at-risk compensation if the board so chooses to have one. The only other thing I'll say, because I'm trying to be quick on this, is when you look at all the other information, there's a lot of unique indicators in here. We tried to put both the KPI description as well as where we got it from. So for example, the way that I see this happening is, let's say the board comes back next time, the first thing that they would do is take a look at that balanced scorecard and say, yes, we agree with these pillars, but maybe they'll say we don't want compliance, we want something else on there for the management at risk piece. So that would be the decision point number 1. Decision point number 2 would be the weighting of each pillar. So maybe you say operational efficiency is important, but it's not 30% important, we believe it's 20%. I got the numbers again from publicly available information used across different health systems across the country. That's how I came up with the team came up with the percentages, but again, they're subject to change. And then the third piece is, once you develop the overall pillars and the weighting of each, the third piece would be, I'm sure the board is going to want to have a comfort level in terms of, if you look at, that's when you start to get specific, and you say, okay, for the KPIs on quality, I want to look at, and patient safety, for HCAHPS, for example, then you're going to get into, what are we going to set the targets at? My recommendation would be to have a threshold, that's the lowest number that we're expected to hit, and then you would have your stretch goal as well. And some of the questions in that meeting, I'm sure will be asked, how did you come up with the target? And for HCAHPS, for example, what our answer would be is, look, our long-term stretch goal is the 90th percentile, that's where we want to be. Today, for the system, this is just an example, if I said we were at the 45th percentile, the goal is to get to the 50th percentile, and then you would ask, why the 50th, why not the 60th? And our answer would be, we utilize Press-Ganey, and we ask Press-Ganey, and they have these reports, what do the top decile performance improvers improve in percentile metrics year over year? And the answer will likely be, 5%, which is why we chose to be a top decile performer improver. We're gonna get to 50%, and that's our threshold. If we set it at 90% year one, it's kind of an irrelevant goal because no one's gonna hit it, and then you don't incentivize people. And we can do that with each individual metric that's in there. So in 5 minutes or less, that's
When did you develop this?
I want to say it's 3 months ago. About 3 or 4 months ago, we put this together. There was a lot of different things out there that were in their own. So Quality, for example, was doing their own scorecards with everyone for a long time. We had some for productivity. Most of the operational efficiencies was basically just make it to budget. So we created this a few months ago and then set the targets based on the indicators that we thought were best practice and achievable.
And you tracked it back to 2017?
Yes.
It also comes through like the HCAHPS. We've been doing that, as Gino said, for about 10 years.
So this information was somewhere, it just wasn't compiled like this?
Yeah, so
Yes.
what we did is we put it all together. What we felt was the most important with the help of Lee Gazzy, and you can see all of the benchmarks and all the research we did to help us come up with what we thought would move it and move the organization.
And I have to say, the Maria Chereva, who's process improvement czar in the system, put all this together, and conglomerating this and making it automated is an incredibly complex task, and she did a phenomenal job with it. So we're really impressed. Yes, she's a Six Sigma black belt.
So I like the layout of the thing. I think the definitions and the measuring tools were attached somewhere, weren't they?
Yes.
Are they?
It's on the first, I believe it's on the first page,
Yes.
right behind tab 1. That's where it has some of the definitions and the KPI
Okay.
descriptions.
So I see those. So I think in operational efficiency, there needs to, we keep talking about budget. We are budgeting to lose, right? So we keep talking about budget. I think a couple of things that might need to be added, tax rate reduction needs to be a goal in operational efficiency. Where are we going? What's our ultimate goal? On all of these, we should have the ultimate goal. If our goal is to get to 90%, I know you're not getting Press-Ganey from 50 to 90 this year. I don't think anybody here expects that. What is our leap next year? To 60, following year 70? We should have our ultimate goal, and then what our goal is for next year. Then the year after that, it should move up. The tax rate reduction is critical to put in here. The taxpayers have footed the bill long enough. It's time to start reducing that. I also, the client satisfaction portion, I mean, they're in here, right? Where do they go? Global rating of the hospital.
Yeah, the HCAHPS.
Communication with nurses and willingness to recommend. Now, those are things you're gonna get off Press-Ganey, right?
Yes.
So that's as good a tool out there as you're gonna find, and most other places use it. What is our goal? Are we actually at 76%?
No, not overall, but on some of them we are.
So are these numbers placeholders?
So are you looking at the dashboard?
I'm looking at the page after the dashboard. So I'm looking at willingness to recommend. and if you go to September 2017, or actually just go to July 2017, it says 75.8%. Is that an actual number, or is
That's
that?
the raw score.
Okay,
It's not the percentile.
okay. So you'll.
Hey, I'm sorry, and let me explain that. The reason we did the raw scores, and we will present the percentiles, but the reason we did the raw scores is because the way that they're reported don't align with the way, with our fiscal year. So we won't know what the actual percentiles are, but we will know what the raw scores are.
We pay Prestini, right? We can't force them to align with us?
No, because they're using, the percentiles are calculated using the other people in the Prestini network.
So obviously this was to introduce this to the board. I think it's important to add the tax rate. I think it's important to add the ultimate goal. And I also think it's important to expand on compliance. There are only 2 items under compliance. It's only 10 points. And for us right now, we're in the ICU on compliance, and we need to pull ourselves out. 10% of our focus isn't enough. We need a little more there. So that weighting might need to change.
Yeah, and that's that's up to the board. I will mention one thing on the tax piece. We have really considered, should we put it on there as a normal thing or should we not? The reason we didn't is because, and we could add it if you want us to, but the reason we didn't is because to get to the net gain loss of operations, it would be, the target is the budget. And in our budget, we're bringing a reduction in the millage rate. So, we could make it separate, or we thought if the budget's gonna have to be approved by the board, and I'm sure the board is gonna wanna see that reduction. That's why we did that.
So
They're already tied together.
So for me, top of mind for all of you at the executive level, tier 1, should be that tax reduction. When I asked you, Bev, I would have loved to have heard reducing the tax rate. There are a lot of public hospitals who've reduced it down to nothing. It's just something that we need to start thinking about and talking about all the time, getting that number down. It is too high. I get it, I understand why we have it. In my personal opinion, it's a dinosaur that's outlived its purpose. We need to become efficient, independent. And that's, I want to get there. I know you're not getting there next year. I know it'll probably take 5, 6, maybe even more, but we should have that as a driver for us as an organization when you talk about operational efficiency. And that's not just through cuts. That's through revenue too. Revenue enhancements, increasing revenue. We have some robots here going to show tonight that are going to help us in that. There's going to be some incremental gains there that are going to help us. So I love it. I love the idea. I love the way this is laid out on the dashboard. But behind this dashboard, there's a lot of information that needs to be understood, and some of it expanded upon.
I share Commissioner Barry's view on tax reduction. I think I've said it ad nauseum for the better part of 3 years. The only thing I will say on that, though, Commissioner Barry, is it's this board that determines that. And we decide whether or not we're going to lower the mill rate or not. And the only way, at least I think we can do that responsibly, is if, from an operational efficiency standpoint, as well as some of the other metrics, are actually achieved. So I think in many ways, because I have the benefit of having some conversations around this a couple months ago, at least just from a macro perspective on how it was put together. I think if we achieve these types of things, we're moving very much in the direction of continued reduction in taxpayer support, which I think in the better part of 3 years I've been here, we've cut better part of $30 million.
Yeah, and we're gonna bring more back. And I have to say, if someone made one of those pull string dolls of Bev and you go back and read the minutes, every single CEO report, our goal is to continue to improve the quality and reduce the taxpayer burden. So we hear it every day.
Could I ask a question about the HCAPs?
Let me just, if I may, Commissioner, I'm gonna step out. I'm gonna hand the gavel over to the Vice Chairman, because we were supposed to end this meeting 8 minutes ago. So please continue with your questioning and then
So,
that'll be the board meeting off that.
Nancy. Go ahead,
The
Lisa.
HCAPs from April through June 2018.
Yeah.
I don't see any page numbers, but it's quite far back. That's a precipitous fall off. Is there some explanation for it? It's fiscal year 2018 quarter 4.
You're comparing April to
I'm just looking at the trend.
I can tell you that for June and July, it's back up.
So there's no pattern to this?
Not that we can see from there. I mean, Lee reviews it in our monthly MORs of all the facilities every single month. And since we started it, there was a decline, and they being the facilities, put action plans in place for their age caps. And when we socialize these goals to them, their action plans correlate to these goals. So now you'll start to see, so for June and July, a lot of these numbers are up. North is at the 50th to 75th percentile, and a lot of theirs, BHEP has come up quite a bit. Medical Center and Coral Springs are both making slow improvements.
Can I just make a suggestion as it relates to the purpose of this? Can we focus on the integrity, I guess, of the scorecard approach, as opposed to what any particular result was in a metric, unless the result is the type of thing that raises the question of whether or not the metric is the type of metric we want to measure. I only say that because of essence of time, but also purpose of today. There's a lot of information here, and if we're going to get too granular on actual results, I think it's going to impede any progress on whether or not we're moving in the right direction with the metrics as a whole.
So then let's look at the dashboard, right? Is what you're suggesting?
Well, I think that's helpful. Of course, I'm not opposed to going into the breakout. I just think when it goes into the actual number or the result, I think we're going to get into some.
So on operational efficiency, there are a lot of subsets to that, including getting revenue that you've already earned, denial rates. There's all kinds of issues there that Alan will have to deal with Janice and such. I don't understand why we only have voluntary turnover. Why don't we just have turnover? Why is it just voluntary and not involuntary? A turnover rate is expensive. If we're terminating a lot of people at any level, executive or otherwise, is there something, I can't imagine that all those people are just bad employees. Maybe there's something wrong with our process. So I would want to measure involuntary as well as voluntary. Somebody just quitting versus 100 people quit and 100 people get fired. And what happened? Why they get fired? Is there something wrong in our training? Where is that, and why isn't it tracked?
We do track it. We didn't put it on one of the balance scorecards that we're measured against, just because it's one of those moving targets. If you have a RIF, or if there's years of poor performance and you're making a lot of changes, that's actually a good thing. We do track it. We could add it. Again, it's just, for
It's just a suggestion for as we get into the meat of it. I think it's something we should look at, just like the tax rate, just like the denial issue. Those are things I think globally that we should take a look at, potentially adding. Again, like the format, like the way this is laid out. I like that it shows the different facilities. But those are issues. Vacancy rates create revenue in some instances, but also create chaos and cost on the other.
Any other comments on the scorecard approach, at least?
I assume you will have, as these get reported, I assume, just like I suggested earlier about having the CEO and the CFO come in, possibly having the CEO and the COO of each of the facilities come in to defend their performance on these individual items once we agree with. Because you have them in here. I mean, you have every hospital listed separately, which is perfect. If we're going to do this, when we do review this, which I don't think is going to happen every month, right? Or are we going to do this every month?
I'm used to seeing a quarterly board review of this.
Well, if there's a system that is failing, maybe there should be a threshold. If they're doing it, they might need to explain why they're doing it. If you look at some of these things, some of these are critical. Air embolism, some of these things, if they're not, if we are having problems there at a particular facility, are you prepared to basically speak on their behalf? Or should they be the ones that come in and explain it with you?
I think it depends, and this may, I think you gotta be careful things bleeding over into a level of operational.
It's asking them to defend their performance. I mean, and with that, listen, it doesn't matter to me, but I think engagement at the CEO level, I went and I visited the facilities, and there's fantastic people out there that can articulate this stuff better than I've heard anywhere else. These CEOs, they know this system, they know what they're doing in their facilities, and they know at Imperial Point, he was able to tell me which floor.
Why don't I start off first and then we'll see if you think.
That's fine, but you look at,
Okay.
I mean, Jonathan was able to tell me what floor their press gang issues were, which is impressive, that he knows that he's relatively new on the job, so.